Thank you, everybody, for joining us on this rather nice evening. So next 1.5 to 2 hours. It's slightly disconcerting because I can see my presentation, but I can't see any of you guys, and you guys can probably see me. So if I pull any funny faces, apologies. I've been asked to give a talk, and I was asked to give a talk about 2 years ago, and I thought long and hard about what I should talk about, and so it's all sorts of topics that I've picked out here, and so I'm going to basically go through slides, and if I get to the end of the talk, great. If I don't, it really doesn't matter. The point is that each point should be made well, and so that's what I'm going to do. So I titled it "What Determines What We Say to Patients." Okay, and as the email that was sent to you, you guys are the most important thing in that consultation that we have. It isn't me, and it isn't the nurses, and it isn't the allied professionals. It is you guys, and I sometimes do have to remind people that we are your servants. You pay our salary, and so really, that's where the story starts. Okay, essentially, you are my employer. Okay, and so quite often when I get people coming from, say, elsewhere for second opinions, I will go through very basic things with them, and they will say to me, and I will say to them, "Did you not ask your doctor this?" And they will say very politely to me, "We didn't ask our doctor this because we thought he or she was very rushed, the clinic was very busy, and he or she is very busy." And then at that point, I will remind the patient that they are rushed because they've taken their time with the previous patient, and therefore they need to take their time with you. Clinics run late because we know that things take time, and we mustn't rush a patient because they're at the end of the clinic or because we're running late. It's important to get everything dealt with in that clinic that the patient needs to be dealt with. Okay, and for that reason, what I say to people is, don't leave the clinic room until you have your answers and have your questions prepared. So with those ground rules, I will move on. So disclosures. So I'm going to go through 3 different situations very loosely: the resected patient, the post-surgical relapse patient, and the non-surgical or stage 4 patient. But I'm going to cover them very loosely, but it's broad principles that I'm interested in. So I'm going to cover things, medical nomenclature that we skirt over very quickly, when in fact we leave the patient with a big black hole in their memory and their understanding of the disease that we really don't think we've done. Okay, and so it's basically really about how we communicate with people. And so in order to start with how we should communicate complicated things like prognosis with patients, really we all need to know the basics. And this is just some of the basics. Okay, so nomenclature, so how we name things. Roughly, what you need to know is that there are 3 categories: the neuroendocrine tumors, the neuroendocrine cancers, and then the mixed neuroendocrine neoplasms. Okay, but for the purposes of this talk and for the purpose of this audience, I'm really going to only cover the neuroendocrine tumors. So what are the neuroendocrine tumors? Well, these are well-differentiated cancers. They can go from grade 1 to 3, whatever that means. They have a Ki-67 score or a mitotic rate which is lower than the other 2 types, whatever that means. And within these 2 types, there are 2 types of cancers that we are especially interested in: the typical carcinoids and the atypical carcinoids. And so you'll see I've got a table pulled up, which I often use with the patients that I'm explaining these conditions to. So right at the top of the tree, you've got small cell lung cancer. Then you've got large cell neuroendocrine tumor. Then you've got a gap. And then you've got atypical carcinoid and typical carcinoid. So these are essentially put in the order of aggression, how aggressive a cancer is. So how quickly a cancer can grow and metastasize, how quickly it can spread. And that in these cancers is largely determined by the degree of differentiation and that thing called the Ki-67 score. So it's useful to start with what differentiation actually means. So the Ki-67 diagrams come up first, so I'll explain that. Okay, so Ki-67 is a nomenclature used to kind of determine how quickly cells grow, how quickly cancer cells grow. So you can see the little diagram with the dots at the bottom. And so right at the top of that triangle is what I call the mother tumor, the first cancer that arises. And you can see that it has two arrows going out to two daughter cells. So those are two cancer cells that have come from that mother cell. And then you can see that each of those cancer cells has propagated, so grown, to create two of their own daughter cells. And so every time a cancer cell grows, it basically encourages the cancer to increase in size. And you can see that there are these tiny red dots on the cell membrane of each of those cells as they've undergone division. So as a cell undergoes division, we know that it leaves a little bleb of protein on its surface for a little while, and that bleb of protein we have called Ki-67. And so every time a cell grows, it leaves a little bleb of protein, and the more of those proteins we can see, the more aggressive the cancer is. And we ask the pathologist to count up 2,000 cancer cells and then count up the number of blebs of protein on cells and give us back a percentage of cells which have that bleb of protein on them. So the higher the number of proteins on cells, the higher the percentage, the higher the aggression. And so small cell lung cancer, you can see, has a Ki-67 score of 80 to 100%. So nearly all the cells are undergoing replication. Large cell neuroendocrine tumors have a Ki-67 score between 60 and 80%. So less than small cell lung cancer, but still quite aggressive. Then you have this gray area, which I'll come back to in a second. Then you have the atypical carcinoids, and suddenly their Ki-67 score falls to 2 to 20%. And then the typical carcinoids, 0 to 2%. Now, small cell lung cancers are the most aggressive cancers, and the typical carcinoids on paper are the least aggressive cancers. And you can see that there is a clear correlation between Ki-67 score and the type of histology that they've been married to. So the next thing that you need to understand is what we mean by differentiation. So we know that the poorly differentiated cancers, the small cell cancers and the large cell neuroendocrine tumors, are aggressive cancers, and the atypical and the typical carcinoids are, relatively speaking, less aggressive cancers. So what does degree of differentiation mean? So the best way I explain to the people that come to see me is through Darwin's Ascent of Man. Okay, so you can see the diagram of a series of our species through evolution. And you can see right at the front is Homo sapien, upright man, walking straight. Okay, then behind him is a Neanderthal walking with a club. Okay, so slightly less civilized than Homo sapien, supposedly. Behind that person is a slightly shorter person, less civilized, not able to make tools for himself. And then behind that are two primitive men. Okay, so what has this got to do with degree of differentiation? Well, if you will liken the Homo sapien, the upright man, to normal tissue, then the man behind him holding the club is likened to a well-differentiated cancer. So not quite Homo sapien, not quite civilized. So if you left him in a room, he might keep the room in good nick, but might want to scratch the walls. Behind him is this other creature, the Denisovann, let's say, and that creature is basically less civilized than the person holding a club, and so might not look after the room as well as the person looking after the club, who will not look after the room as well as the Homo sapien, the normal upright person, the normal tissue. Right at the back is this ape-like creature. This ape-like creature will not look after any room that has been left in, okay? And that is likened to a poorly differentiated cancer, so the small cells and the large cell neuroendocrine tumors. And so what's the difference? What is it? Well, the reason we do this is because it gives us an idea about how aggressive a cancer is going to be and how predictable a cancer is going to be. So the well-differentiated cancers tend to behave more like that civilized, upright man, and therefore tend to be predictable. Whereas the poorly differentiated cancers, the small cell and the large cell cancers, tend not to be so predictable. And so that's why when you come to our clinics, we will talk to you about you have an atypical carcinoid or a typical carcinoid, and these cancers are well differentiated, and we will talk to you about the Ki-67 score, because essentially what we are telling you is about the nature of aggression and predictability of these cancers. But you'll notice that there is a gap. The Ki-67 score goes from 60 to 80% in large cell neuroendocrine tumors to 2 to 20% in the typical carcinoid. Sorry, the cat's getting in the way. And so we have recently discovered that there is a group of neuroendocrine tumors which sit in the middle of all of that, which are grade 3. So they are essentially, they look like the small cells and the large cells, but actually are well differentiated. So they sit right in the middle. So that middleman in that diagram is probably most reflective of that type of cancer. And I'll come on to that later on. Just some basics again. So we know that the incidence of these cancers is growing, okay, but that's not because we think that the cancers are becoming more common. It's just that we're becoming better at detecting these cancers in many more people than we used to be. But nevertheless, it's a useful tool because it tells us that lung neuroendocrine tumors require a lot of attention because they are the ones that are growing the fastest. It's important to note that the survival of all NETs has improved over time, especially the GI NETs and the pancreatic NETs. And that basically reflects improvement in funding and therapies. And really, we want the lung NETs to reflect that too. So the scope of this talk is the typical and the atypical carcinoids. How do these cancers present? Well, the average age that these cancers present is between the 4th and 6th decade. The typical carcinoids, they present slightly earlier than the atypical carcinoids. There is a preponderance for women more than men. And from the previous slide, you'll know that typical carcinoids have a better outcome than the atypical carcinoids in terms of survival. It's often forgotten that these cancers, although they are rare in adults, they are the most common primary lung neoplasm in children in late adolescence. Usually it's the typical carcinoids. How do they present? Well, they present with many features, but unfortunately many of these features are non-specific. So they present with shortness of breath, chest discomfort, wheezing, fever, blood loss. Sometimes they mimic infections. Because they are non-specific in their symptomology, quite often it is recognized late that people have these cancers. We all know that there is an associated syndrome with these cancers. Now, I'm not going to spend much time on the syndrome because that warrants a separate lecture on its own. But we know that the lung neuroendocrine tumors are saddled with rare syndromes, more so than the GI NETs. But you can get Cushing syndrome, which is an increased uptake in steroid. We know you can get acromegaly, which is an increased uptake in growth hormone. And of course, the well-documented one is carcinoid syndrome, which I'll briefly cover later on. But it's important to note that these are often overdiagnosed by clinicians and by patients. And many patients think they've got this because the clinicians have told them they've probably got it, but actually most patients don't have this. Carcinoid syndrome is rarer in lung neuroendocrine tumors than it is in other neuroendocrine tumors. However, if you end up with carcinoid syndrome, then you will know that it is more aggressive in the lung neuroendocrine tumours. And this is basically the mechanism. Remember, a lot of these slides are designed for talks that I give to other clinicians, so apologies for the rather confusing diagrams. But essentially, carcinoid syndrome is derived from an amino acid called tryptophan. Tryptophan, in its normal life, is used by our bodies to make vitamin B. However, in people with neuroendocrine syndrome, the tryptophan pathway is converted to make serotonin. So highlight that in black. And serotonin is a fibrotic agent. So as it courses through your blood and it hits organs, it causes fibrosis. And so we know that it can cause, therefore, a triad of problems. So if it's produced in the liver, the first organ it's going to get to is your heart. And so it's the blood in your heart now has got this fibrotic agent in it. And the slowest part of your heart, where blood flows through slowly, is the right side of your heart. And so as a consequence, the valves on the right side of your heart get affected by this syndrome. And one of those valves is called the tricuspid valve. And then from there, from the right side of your heart, it goes into your lungs. And we know that in your lungs, as blood is trying to get oxygen across and carbon dioxide thrown out, blood slows down. And if it's got this serotonin in it, it's going to cause fibrosis in your lungs. And so that can manifest as wheezing and in some people shortness of breath. And then from the lungs, that blood goes into the left side of your heart, which is very muscular, high volume blood passing through the left side of the heart. So the serotonin has no time to damage the left side of the heart, but it then goes into your what we call systemic circulation, which is the rest of your body. And in the rest of your body, we know that the blood slows down in two places: the skin to cause flushing and the gut to cause diarrhea. And that's all because your blood is then at that point loaded with serotonin to cause these problems. And we know that we have very effective management to shut down carcinoid syndrome. And that's about all that I'm going to say about carcinoid syndrome, because that does warrant a separate lecture. So the first topic I really want to hit in this lecture is the post-surgical patient that comes to see the oncologist. So these are patients who have had their surgery and now are joining the follow-up clinics. And we know that 70% of patients that present in clinics like my clinic are post-resection patients. 30% are stage 4, 70% are post-resection. Most resections occur following the discovery of an incidentaloma. So people don't know they've got this cancer. It presents accidentally through a chest X-ray or through a CT scan or through some other manifestation, which isn't necessarily because the general practitioner or the secondary physician believes that they've got a neuroendocrine tumor. And so that can sometimes delay diagnosis, and that causes some frustration. Some patients, and this is important, have been told by their cardiothoracic services or by their GP or by somebody else that they've had a benign tumor removed. And that can get people into an inordinate amount of trouble. I saw somebody a while ago who was actually a second opinion, who'd nearly got in trouble with the law because he or she had filled out an insurance document, and in that document they'd been asked whether they'd ever had a malignant cancer, and they'd filled out no, because their clinicians had told them it was a benign entity. And of course, when they came to claim the insurance, they were initially accused of fraud. It was very rapidly cleared up, but it is important to understand these are bona fide cancers, and they need to be treated like bona fide cancers. Most patients are told they will recover in 3 to 6 months after surgery. Well, that's not true either. having followed patients up for the last 24 years, 25 years now, a quarter of a century, I can tell you it takes about 2 to 4 years for people to recover from surgery. There is physical recovery, so patients have to recover from the organ that's been taken off them, so part of the lung, so the rest of the lung has to fill in that gap. And so as it's filling in, that can manifest as cough. So people often have a cough after operation. To get to the lungs, the surgeons have to cut through muscle, sinew, and nerve. And so shortly after their surgery, a lot of patients will get nerve pain as the nerves try to re-innervate through their ribs. And so for the next 2 or 3 years, they can get discomfort. And of course, many people want to get back to work. And what they find is that 80% of their physical activity has returned in about 3 to 6 months. But when they push themselves to that 20% extra to get the 100% activity that they used to have, they find that they struggle, and that can sometimes frustrate them. That bit takes about 3 to 4 years to come back. And then there is, of course, this thing called psychological recovery, living beyond cancer. So they've had their cancer removed. They have been made aware that there is a chance that it can reoccur. And so they are on follow-up. And so every symptom a patient gets, they refer back to whether it is the cancer that has reoccurred or not. And so psychological recovery can take a long time, and some people may not recover from that. And therefore, they need support. Okay, they need reassurance, and they need a contact, a way of contacting a team if they're worried. And then people forget there is recovery of time lost to hospital follow-up, so going from hospital clinic to hospital clinic, and finances to support that. So while they're in my clinic, they're not at work, so they're losing on financial benefit. They've had to get there by taxi. I'm going to ask them to come back in 3 months' time. All of this is what I call financial toxicity. So all of this needs to be covered. And it may not be helpful to a person initially that we are aware of this kind of stuff and we mention it, but actually for a person to know that we are with them and we do appreciate these problems and we are ready to try and tackle them if they become problems, I guess is important. So when you get into the clinic, your first clinic, post-resection, what are the questions that you need to ask? Okay, so, and what should we be communicating with you? And so really it comes down to how we communicate things. So it is essential that somebody goes through the pathology findings with you. Okay, so when your tumor is taken out, the pathologist will look at that under a microscope and give us a pathology report. And that pathology report will give us a lot of information about what may happen beyond cancer. And so it's important that we talk to you about it and then try and translate that to something that you can translate for the future. So, first thing that we should say is tell you which histology has been diagnosed. Is this an atypical carcinoid or is this a typical carcinoid? Is this a supracarcinoid? And why? We should talk about whether it was an R0 resection, an R1 resection, or an R2 resection. So what is an R0 resection? Well, an R0 resection is where all the cancer was removed and there was healthy tissue all the way around the cancer. Okay, so in other words, the surgeons removed the cancer, but also removed healthy tissue around it, leaving no margins. An R1 resection is where the surgeon's knife went very close to the resection margin where the cancer stopped and healthy tissue started. And R2 is where they have overtly, sadly, left cancer behind because technically they couldn't remove it. Okay, all of those have different consequences in how we follow people up. Clearly, with R0 resections, we can relax off a little bit. R1, we're a little bit het up, but R2 needs to be followed up very carefully. As important as the R status is the nodal status. So Surgeons, when they remove cancer, they will remove the lymph nodes in the vicinity. And those nodes are a surrogate marker of what else may be going on in your body. The more nodes that are removed, the bigger the operation. So it instills me with confidence that it's been a big operation. But the more nodes that are positive, the more chances that this cancer could come back in the future. And I'm going to cover that in coming slides. And then, of course, I've mentioned the Ki-67 score. It is important that we cover the Ki-67 score. So many centres will say, well, the Ki-67 score isn't in the World Health Organization classification yet. Well, it may not be, but actually it's a very useful tool for clinicians to know about the degree of aggression of a cancer. And I'll show you some slides that give us that information. Okay, so they should cover the Ki-67 score. Now, as far as I know, most centres are doing the Ki-67 score because they've realised it is so useful. And the question that's often forgotten by patients and by clinicians is whether there was any background DIPNEC. Okay, and I'm going to describe DIPNEC in the coming slides. So DIPNEC is an acronym for diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. Okay, and I'll describe the phenomenon in the coming slides. And it is important that you ask whether that was present or not, because it has prognostic significance. Okay, and once again, I will cover that. Okay. And then, of course, you need to sit there with the clinician who's explained the pathology and say, how does this translate to outcomes for me? Okay, because there's no point in me just going through all of this without actually trying to tell you what this means for the future. Okay, and we have enough information to give us that idea. Okay, and then at the end of that, of course, never go away from a clinic without knowing what the next step or steps are. Okay, never get left without knowing that. So the plan for follow-up. What is the plan for follow-up based on the rationale that you've just given us? Okay, so if the cancer is more aggressive, you would expect the clinician to say, I'm going to follow you up more carefully and more frequently. If the operation was successful and it was an R0 resection and there was no lymph nodes, then I would expect them to say, we are going to follow you as per protocol. And their protocol should be either based on the ESMO guideline, but preferably the ENETS guidelines, which are, I think, a little bit more sensible. Just going to the risk of relapse and where clinicians come from with their information. The SEER database is a database collected by the Americans, and it's updated reasonably frequently. Okay, has allowed us to kind of classify these cancers, and we know that as we go from stage 1 to stage 4 cancer, the risk of relapse and metastatic disease increases. But we don't really need to even complicate it like that. Small cancer versus big cancer has a higher risk of relapse. Lymph node metastases have an even higher risk of relapse. So in this diagram where, and you have to apologize for me using a bald man, it wasn't intentional, you can see that I've put a red ring around a red square around the cancer, small cancer, big cancer, cancer with a lymph node attached to it. The blue circles are meant to indicate the presence of micrometastases. And you can see the risk of micrometastases, a disease that is invisible to any scan we have to offer, increases as we move from small cancer to big cancer to lymph node metastases. And so what increases the risk of micrometastases is, of course, worsening histology. So typical neuroendocrine tumours have the least risk of micrometastatic disease, followed by atypicals, followed by these supracarcinoids, supra-atypicals. And of course, increase in lymph node burden increases the risk of micrometastases, because lymph nodes are a surrogate of this phenomenon going on. How else has the cancer got from the primary cancer to a lymph node? It must have gone through either lymphatics or the bloodstream to get to that lymph node. It is always useful to know who is likely to relapse and who is never likely to relapse. What we definitely know is histology is an important factor in relapse. So clinicians are very used to looking at these graphs. These graphs are called Kaplan-Meier graphs, and believe it or not, and I apologize for this, I am going to try and explain these to you in the coming slides, okay, because they are important. So as a graph falls, so each dot in these graphs represents an individual person. And as that person sadly passes away, the graph falls. So the quicker a graph falls, the more aggressive a cancer is. And you can see the solid line, the top line, signifies typical carcinoids, and the bottom line signifies atypical carcinoids, which reflects the more aggressive tumor, atypical carcinoid. And you can see a similar pattern with lymph node positivity. So if you're lymph node negative, your graph falls less than if you are lymph node positive. So we definitely know that these two situations need to be looked at very carefully, and a person needs to be followed up very carefully. And you'll have to excuse this stuff about multivariate analysis, etc. This slide was based for clinicians. But essentially what I'm saying here is that histology and lymph node positivity are probably the most important factors in deciding what step to take next with the patient. So I've already kind of described this. So this is the classification and how we classify these cancers. And I've explained that mitotic index is what is on the World Health Organization classification, but many clinicians actually now prefer the Ki-67 score because it gives us a much more useful, continuous idea of how aggressive a cancer is. So I'm not going to dwell too much on this slide. But why it's important is because of this graph here. Okay, and so this was something that we published many years ago now, and basically it shows that so once again you've got three graphs here. There's a graph at the top which falls off less than the other two graphs, and that graph at the top is one whose patients have a Ki-67 score less than 5%. The middle graph, Ki-67 score between 5 and 10%. And the one that falls off the steepest, so the most aggressive, are those with a Ki-67 score greater than 10%. So you can see why clinicians really want to know what the Ki-67 score is, because it gives us prognostic evidence about what may happen to a patient. Okay, so I said I would cover DIPNEC with you, okay, and I'd explain why it's important that we should cover DIPNEC, okay. So what is DIPNEC? So I'll explain that it's an acronym for diffuse idiopathic meaning we don't know what the cause is, pulmonary neuroendocrine cell hyperplasia. Hyperplasia meaning it's not cancer, it's cells that are growing rapidly, okay. It is a proposed precursor of typical and atypical carcinoids. In some patients, it can be the pre-malignant condition. And what it does is it causes hyperplasia, and I think here it is. Okay, so here we have a diagram with cells at the bottom. Okay, I should have labeled these. The blue cells are neuroendocrine cells in your lungs, and the clear cells are what we call the alveolar cells, and their job is to take in oxygen and throw out carbon dioxide. So these are right at the bottom of your lungs in what we call the alveoli, okay? And they're the ones that gas exchange, help you breathe, okay? So they take in oxygen, throw out carbon dioxide. In certain situations, the body will tell you that you need more oxygen and you need to throw out more carbon dioxide. That rate of diffusion is controlled by your neuroendocrine cells. At that point, your neuroendocrine cells will start releasing this thing called GRP, which is a hormone, which will affect those alveolar cells to encourage them to change the rate at which they are transferring oxygen against carbon dioxide. What happens, though, if those alveolar cells become less sensitive to this hormone? Well, if they become less sensitive to this hormone, the neuroendocrine cells think, well, maybe it's because I'm not producing enough of the hormone. So what they start to do is produce more hormone, and the only way they can do that is by undergoing hyperplasia. In other words, creating more neuroendocrine cells. And you can see now there is a stack of blue cells. Okay, the blue cells, they're not malignant, and they are now producing much more GRP. But if you undergo hyperplasia of any of your cells, there is a chance that those cells will eventually, the replication will go wrong and they will create a mutant, which is a cancer. And you can see that one of them has created a red cell, and that is now the initiation of a mother tumor cell. Okay, and that phenomenon where you get hyperplasia, an increase in this hormone GRP, and tumulates is called diffuse idiopathic neuroendocrine cell hyperplasia. And that can happen in some people with typical and atypical carcinoid. And how we find them is that they often have these cancers in multiple areas in their lungs. And you can see that in the diagram. They don't just have it in one area, they have it in multiple areas. And quite often I will get called by the cardiothoracic surgeons to say, what shall I do? Do I remove the biggest tumor or shall I leave it alone? Because they seem to have multiple tumors. And I will say that they've probably got dip neck, and most of the time I say leave it alone. Okay. Dip neck occurs more commonly in females. It occurs in the 5th to 6th decade. Often people are very weak but ex-smokers, and rarely it has been associated with sensorineural deafness, so people with slightly deafening slight hearing loss. And quite often they will have gone from clinic to clinic to clinic, from GP to GP to GP, to asthma clinic to asthma clinic, with people telling them that, oh, you've got asthma, you've got bronchitis, and then eventually somebody will take a biopsy and find that actually they've got dip neck. Okay, and it can be a cause for progressive shortness of breath. So why is it relevant to people that have had neuroendocrine tumors resected? Well, it's relevant because what I've found over a quarter of a century of following patients with dip neck and a quarter of a century of following patients without dip neck is that the patients with dip neck seem to have a cancer which is a lot less aggressive than those without dip neck. So these cancers don't tend to metastasize, so they don't tend to spread to lymph nodes or to the liver. They tend to stay in the lungs, and the main problem with these with the patients that have been diagnosed with dip neck is that they really have breathing problems rather than cancer problems. So it is important that we know from the histology whether a person has got associated dip neck, because it can be prognostic in a good way. And of course, the question about relapse comes up. When is the cancer likely to come back, and where is the cancer likely to come back to? Okay, so these questions are sometimes deemed difficult to answer by clinicians, and the reason for that is because for centuries people haven't collated the data. Okay, so for the last quarter of a century, the Christie, we've been collecting that data. Okay, but here I'm afraid that the lecture has to go into a bit of a maths lesson, so I apologize, and I've explained some of this already, but I am going to explain survival curves to you. Okay, so survival curves, we sometimes call them Kaplan-Meier curves. Okay, are where we get information about relapse patterns from. Okay, so on the y-axis we plot the number of people alive, and on the x-axis we plot time. Okay, and as I explained before, we start off, let's say, with 100 patients, and we can see that line represents 100 people. And because none of them have died initially, the line is completely horizontal. But then one person dies, and because of that, that person is knocked off. So the number of people alive is now 99, and so that graph falls. But of course, the other 99 people are still alive and time goes on. So it's a horizontal line again, but at a lower level. And then another person dies, and so the graph falls. And then it carries on because time is carrying on. And then let's say 2 patients die here. So the graph falls more steeply, but then carries on. And so on and so forth. And so if you have lots and lots of patients, so thousands of patients, you won't see this stepwise progression. What you'll actually see is a very, very smooth curve. Okay. And that curve is called a Kaplan-Meier curve or a survival curve. And that is basically how they are plotted. Okay. But they give us really useful information about relapse patterns and survival patterns. And they give us information about this word cure. Okay. So I've already explained to you that as this graph is falling, people are dying. Okay. But at some point, that graph stops falling again and it just becomes horizontal. And it doesn't change from being horizontal. And that from that point onwards, that is what is defined as cure. Cure is not really a useful phrase in oncology unless it's relating back to these types of survival curves. Okay. Unfortunately, many clinicians give a treatment and then they will say, we think you're cured. But actually, you now know it's time honored. Okay. And it depends on which graph you're on. So the graph for a typical carcinoid will be very different to the graph of an atypical carcinoid patient. Okay. And that I'll illustrate here. So here's that same graph again. That graph, you can see it falls off a lot faster. Its horizontal point comes a lot quicker, but it is lower than the black line. And that's because the top line reflects typical carcinoids and the bottom line reflects atypical carcinoids. Then you can see that there is a blue line that I've just flashed on, and that is much higher. It doesn't fall off as quickly as the other 2 lines. And that is an example of what happens when a group of people, all those patients in this graph, are put on a medication that is useful, that actually helps them. And when we present trials to each other, this is what we're looking at. We're looking at whether these survival curves go up and down depending on the treatments that they've had. And you'll all know that sometimes we compare a particular drug to another drug. Well, this is what we're looking at. And you can see that this graph is higher than all of them, and that's great because that must mean it's a really good treatment. But you'll notice that the bottom graph has become horizontal, the second graph has become horizontal, and therefore we're hitting that point where those patients are no longer relapsing. So sadly, the people that were going to die have died, and now we're getting on to those people that are possibly cured. And you can see the third graph hits the horizontal. But you can see that the fourth graph actually never hits the horizontal. Okay, it's always falling off, even though it's in a better place than all the other graphs. And many cancers are like that. Many cancers, we still haven't worked out where that horizontal part of the graph starts. Okay, and the atypical and the typical carcinoid may well be in that group of people. Okay, nobody really knows what their survival curves really look like. And we're only going to know that when globally we club together and put everybody's data together. That means we have to collect the data, okay? And that takes a lot of effort. So people ask, well, if it's going to relapse, how is it going to relapse, okay? And so I've just put it in simple percentages, okay? So we know that both cancers, they can relapse at different rates. The typical carcinoid between 5 and 15% relapse over a period of time, over, we think, about 15 years. The atypical carcinoids relapse between 20 and 50%, and they relapse a little bit sooner, within 0 to 5 years. Okay, when they relapse, they have a similar pattern of relapse. About half the patients relapse into the liver, so these cancers have a predilection for the liver. A quarter relapse into another part of the lung. A fifth then relapse into the lymph nodes and the bones. Okay, and then there are other places that they can relapse into: skin, brain, etc., etc. Knowing this and knowing the relapse pattern or the relapse rates really helps us organize which tests we should do for a patient and how often we should do these tests and how often we should actually see the patient. Okay, so when we kind of see you in clinic and we say, okay, we'll see you in a year's time and we'll do a CT scan in a year's time, this is the mathematics and the optics that go behind that kind of decision. But there is another word that you need to be aware of, okay, and that is micrometastatic. Okay, so I did say this talk was rather random, okay, but this is another important phrase that you need to be aware of. So here we have that man again, okay, and that green blob is a cancer, okay, and that cancer, actually, I'll just get a pointer. Oh, it doesn't matter. Okay, so that green blob is a cancer. And of course, a dutiful surgeon is going to come along, do a CT scan and say, right, I'm going to remove that cancer. But unbeknown to the surgeon, you can see the red arrow pointing towards 5 dots. Those dots are micrometastatic disease, and those dots can't be picked up by any mechanism that we have currently. Okay, so a person with micrometastatic disease, there are no clues that they really have micrometastatic disease. So the dutiful surgeon will go ahead and remove that cancer. You can see that they've removed that cancer, but later on, at some time point, that disease will start to grow. The micrometastatic disease will start to grow and start to cause problems. And really, there is a race on right now to try and find a better mechanism of looking for micrometastatic disease or picking up macrometastatic disease a lot faster than we are currently, because we know that if we pick it up late, it is associated with worse outcomes. Okay, certainly in other cancers. So when you have surgery, this is why you're on follow-up. It is looking out for micrometastatic disease that may become macrometastatic disease. Okay, so the next question that we often get asked about the surgical patient is, well, okay, I've had, let's say, an atypical cancer removed and I'm lymph node positive, and it was an R1 resection, Prof. I'm worried about relapse, and you've told me that there is a 25 to 50% chance of relapse with atypical carcinoid. Why can I not have adjuvant chemotherapy to stop the micrometastases, to suck them up so that they don't cause me a problem later on? Okay, and I've already explained how these cancers relapse. If you're going to give adjuvant chemotherapy, you're going to you obviously have to give it before relapse. You have to give it close to the surgical point. Okay. And so when we base our decisions on giving adjuvant therapy or not, it is based on the evidence before us. And there are 3 guidelines that we really base our decisions on: the ENETS guidelines, the NCCN guidelines, and the NANETS guidelines. And guidelines, you've got to remember, are based on evidence. Okay, when there is no evidence, we will weight those guidelines according to that. Okay, so in other words, there are really good guidelines which are based on really strong evidence, what we call level 1 evidence, so published in good journals, or someone's in what we call a meta-analysis, okay? Or we base them on poorer evidence, level 4 and level 5 evidence. So that could be retrospective data or real-world evidence on single cases, okay? And unfortunately, in the adjuvant setting with these cancers, a lot of our guidance is based on quite poor evidence. And as a consequence, the 3 guidelines don't really agree with each other. The ENETS guidelines says that you can consider adjuvant chemotherapy for those that have had atypical carcinoid removed, that are lymph node positive with a high proliferation index, as I've stated before. The NCCN guidelines say give it possibly for those that have stage 2 or stage 3 atypical carcinoids, so they are lymph node positive essentially. And the NANETS guidelines say we don't recommend it. Okay, and they don't recommend it because the other 2 guidelines don't actually say which chemotherapy you should give, because not even that has been standardized. So If you give chemotherapy to a person in the adjuvant setting, then you have to explain to them and counsel with them that that chemotherapy can have legacy toxicity associated with it. And if we give that chemotherapy to try and prevent relapse, there is a lack of evidence. And this is the real difficulty in the situation that we get caught in. Why isn't there evidence? Well, about 15 years ago, I tried globally to set up an adjuvant study, and it took about a good year of my time and effort to try and set it up, but it was too difficult. And the reason it was too difficult was because atypical and typical carcinoids are a difficult group of cancers to work with, okay, from a statistical point of view. So selecting the patient for an adjuvant study, there are three things that you have to consider. Number one, you have to say which patients you want to select. Well, that's easy. I want to select adjuvant patients. Well, which adjuvant patients? Well, I want to select those that have the highest chance of relapse. Okay, so those are the atypical carcinoids or the lymph node positive atypical or typical carcinoids. Okay, if you pick patients that have very little chance of relapse, then nobody will ever fund it because it takes too long, okay, for a trial to finish. And then, of course, you have to choose the adjuvant therapy. Which therapy are you going to choose, okay? And to answer that question, you have to answer questions about responsiveness of that chemotherapy and toxicity profile. In other words, can the cancer shrink? And what toxicity legacy are you going to leave the patient, okay? And of course, there is no standardized chemotherapy with these cancers. And then, of course, we come to the third problem, which is a real problem, which is study design. In order to do a trial, you have to do something called a power calculation. You have to compare one group against another, and you have to try and predict the difference between those two groups at the end of the trial. And in order to do that, you have to understand the survival curves of those two groups. Now, we don't have that level of data with these cancers, okay? And so therefore, you can't power up a trial. And therefore, if you can't power a trial, you can't work out how many people you need in the trial. If the difference between two groups is small, so in other words, if you give adjuvant chemotherapy to one group and no treatment to another group of patients, and at the end of 15 years of follow-up, you're going to improve the outcome for 0.1% of the patients in the adjuvant group, okay, the power calculation will mean that you will need probably 20,000 patients, okay? And to run a trial with 20,000 patients in, it requires an inordinate amount of money, okay? And so that's one problem. The accrual rate is another problem. How quickly you can recruit to a trial. It costs a lot of money to run a trial per day. And the bigger the trial is, the more money it costs. And so any grant supporting committee will be keen to know whether you are going to start and complete the trial quite quickly because, of course, money is a constraint. And then, of course, there is the thing called event rate. So if you pick the wrong group of patients, those patients that aren't going to relapse very quickly, then you're going to be waiting a long time to see anything happen before you can say there's a difference between two groups. And so without having information on relapse patterns and who relapses, with more detail than just saying it's because of histology or lymph node positivity, it's very difficult to get people interested in doing a trial like this. So evidence is generally lacking. So current practice is, of course, we give adjuvant treatment to very selected patients, okay, and then we audit them to see if it makes, any difference. And the audit may take maybe 50 years to do because you may only give adjuvant treatment to 5 patients in a working lifetime. Basic investigations that should be done post-surgery. So confirm histology. Is it a typical carcinoid or an atypical carcinoid? poorly differentiated or not. Ask pathology review. I always ask for a second opinion on the pathology, okay, because different pathologists can get it wrong. Ask if dipnec is present. Confirm the stage of the cancer. So contrast-enhanced CT scan of the thorax, abdomen, pelvis remains the gold standard, not a gallium-DOTA PET scan. Okay, gallium-DOTA PET scans give you another type of information, but they are less. They have less detail in them. Okay, so the contrast-enhanced CT is the gold standard. Confirm the functional status. So I said to you right at the beginning that a small number of patients do have secretory neuroendocrine tumors with syndrome. So do the blood test just in case they have that. Okay, and then of course follow up. The clinical consultation is probably the most important thing. Okay, trying to find out whether a person has relapsed using CT scans on their own is not a recommendation. Okay, so this should always be done driven by established protocols. So it shouldn't be made up. Okay, so the patient should have somewhere to reference when the follow-up, how the follow-ups are coming about, why they're being followed up, and how long that's going to go on for. Okay. And of course, during follow-up, there will be the need to do bloods and contrast-enhanced CT scans, and occasionally the gallium scans, occasionally MRI scans if people want to avoid the radiation. The clinician needs to listen to the patient, and the patient needs to listen to the clinician. It's a partnership. If somebody does relapse, what needs to be discussed? Okay, and so this is where both the patient and the doctor need to eat the frog. Eat the frog is a phrase I learned from my little boy's teacher. She said he doesn't like learning difficult things. There's certain things he doesn't like, and he's got to learn to eat the frog, which means learn the things that you don't like learning. And this is exactly the same for doctors and exactly the same for patients. Doctors don't like talking about prognosis because it upsets people, because it adds a finite quality to a person's life. Okay, patients don't like hearing it because it gives them an idea of what might happen in the future. Okay, but prognosis is not a straightforward discussion, and I'm going to once again use an example, a mathematical example, for you to understand that prognosis is actually not an easy beast to talk about. Okay, but it is something that I encourage people to try and talk about. Okay, and don't worry, in this talk I'm not going to shout out any figures, but I do want to explain how it's derived. Okay, so prognosis I think should be discussed, but only if the patient gives consent. Okay, but if they don't give consent, they should be counselled and reassured that they've not said anything wrong, and at any point if they do want to talk about it, then please, they should come back to us. Then, of course, treatment options. So like I said, never leave a clinic in the dark, okay? Know what the immediate steps are going to be, okay? So many people want to talk about, but what if this happens, this happens, this happens? And quite often I will curtail that part of the discussion because it's a complex discussion. And actually what we need to know is what the next step is going to be, okay? And what may follow that step, rather than the complex discussion about the lack of evidence of this treatment versus that treatment, or the evidence for this treatment versus that treatment. It's probably best to talk about the treatment option that's immediately facing us. So the non-resectable or the stage 4 disease patient. Okay, so I've kind of already gone through this. Okay, the kind of the relapse patterns. What are the commonly asked questions? What symptoms should I expect? Can I have immunotherapy? Should I get cancer tested for actionable mutations? Are there any trials? What is my prognosis? Okay, so what symptoms should I expect? Well, so if you know that this cancer has a predilection for the liver, when it goes to the liver, we know that it can cause something called anorexia, so loss of appetite. Okay, it can cause fatigue. Both of these symptoms are very vague symptoms. Okay, so they can happen in any situation, many situations. They can happen if your thyroids are not working properly, for example. And so I don't necessarily like to labor the point with particular symptoms. What I say to people is, you know what your quality of life is currently. If you stray from that quality of life, let us know, okay? And we will try and work it out, because the last thing we want to do is burden you with more imagery of what relapse looks like, okay? There aren't any red flag symptoms that point to a carcinoid relapse. So for that reason, we try not to talk too much about it, but I have given you a clue that if it's the liver, of course, you get fatigue, anorexia. If it's the lung, common sense, you're going to get short of breath. If the bone, you might get bony pains, okay? Can I have immunotherapy? Well, before I go on to that, actually, I should cover prognosis right at the bottom, okay? So this is an odd example, okay? And so you have to bear with me. So if I plot on the y-axis the number of women and on the x-axis the height of those women, okay, then I'll find a range. Okay, there'll be some short women and some tall women, okay, and then some people in the middle. If an alien comes from Mars and asks me, what is the height of women? I look at that in the UK. I look at that alien and say, don't be ridiculous. There's a different range of heights. And that alien will say, well, I'm only asking for the average height. So what's the average height? And at that point, I'm going to be very difficult with that person and say, well, which average do you want? Okay. And that's important in the medical field. Which average do we talk about? Because that's relevant to you. Okay. And I'm going to try and explain that. So here we have the height of women. So the red circle demarcates very short women, and the red circle on this side, very tall women. But you can see in the middle, there's two rugby posts up, that's the average height. Okay, so the short women might be 3'10", tall women might be 7'4", but most people are average. Okay, and there are three averages: mean, mode, median. Okay, mean is the one that we all know about, where you take the total number of women and divide their height by that total number. Okay, mode is the most popular height, which not relevant. The term that we use, the figure that we give people, is the median figure, the middle figure. Okay, so if I line up 100 women, it'll be that middle person, the 50th person that I will pull out and tell the alien that's the average height of women. So that median figure, demarcated by that dotted red line, will mean that that 50th person is the person that I'll quote everybody, but I'm going to get it wrong by definition for 49 shorter women and 49 taller women. Okay, and that is the frailty of median. Okay, so it's important when you sit there listening to a clinician go on about prognosis that they are referring to a median figure which may not represent you. Okay, and really the question you need to ask is, well, what does that person look like, that median person? And am I that median person? Okay, so if I then replace height of women with survival on the x-axis, very long survival, very short survival, then you can see that how this plays out, that the figure I quote you is the median figure, which is non-representative for 49% of the patients to the left and 49% of the patients to the right. Okay, and I certainly talk about how you move that median figure for the individual in front of me. Okay, so you empower regarding how you can move that, what a person can do to try and move that figure. Okay, so that's prognosis. So histological factors, so I've kind of covered this already. Okay, so I've said that the grade 1s and grade 2s have a better outcome than the poorly differentiated cancers, and I've explained what these poorly differentiated cancers align to in terms of the ascent of man. I'm not going to go through that again. Okay, and I've explained that this missing link is this supracarcinoid. We don't know much about supracarcinoids just yet. They've been defined over the last 5 years, but we do know a little bit now about them. Okay, so through publications like this Nature publication, we know that there are two prognostic atypical neuroendocrine tumor groups. There is a good prognostic group, and they have a very good 10-year overall survival, and they overexpress a protein called DLL3, and they overexpress an adhesion molecule called OTP. OTP is an adhesion molecule. In other words, it adheres one cell to another cell. So it sticks cells together. So you can imagine that if you have a sticky cancer that can't just spread, then a surgeon could deal with that and remove the whole thing, and it hasn't had a chance to spread. If you are lacking that particular protein, then you've got a cancer that's friable. It can move around, okay? So it makes sense. So we know that there is a good prognostic group which overexpress DLL3 and OTP, and we know that there is a poor prognostic group, and we call them the supracarcinoids, which express DLL3, which do not, express DLL3 and do not express this adhesion molecule called OTP. Is this standard of care? Do we test these things in our histology? No. So currently at the Christie, we're desperately trying to validate these to make sure that the rest of the country are using them as a prognostic indicator. But of course, it costs money. And in order to get the commissioners to spend that money, you've got to provide the evidence. And that's what we're currently collating. So there's the supracarcinoids. Okay. So pharmacological management of lung NETs. So I'll finish soon. Okay. So should we look at molecular mutations that could be actions? This is a common question that I get asked. People say, look, there's a company that's saying if I spend £5,000, they will do a molecular analysis of my cancer and tell me if there is a mutation that a drug can be used to deal with that cancer. Okay. And quite often I'm a little bit discouraging of people doing this. And the reason for that is evidence-based, because this is an example of how evidence-based can help us inform patients. Okay, so if you take precursors of neuroendocrine cancers, okay, we know that there are the small cell cancers and the large cell cancers. Okay, and then we know that there is DIPNEC, which is a precursor to the tumorlets, which is a precursor to the typical carcinoids and the atypical carcinoids. And what SCARP, the group, SCARP et al. Have done, okay, what they have done is through each stage molecularly analyzed these cancers to see how the mutations increase as each step in the malignancy is taken. So from DIPNEC to tumorlet, from tumorlet to typical carcinoid or atypical carcinoid. And what we should see is more and more mutations happening to make the cancer and then make the cancer more aggressive. But in fact, we don't see that, okay? It appears like that this cancer, neuroendocrine tumors, don't have many mutations. The main mutation they have is the MEN1 aberration, which we have known for many, many years about, okay? So in terms of actionable tumors, actionable mutations, there isn't much to go by. Whereas if you look at the small cell and the large cell tumors, they have TP53, RB1, PI3 kinase, AKT, mTOR. These are all actionable tumor markers, okay? But the NETs don't, okay? And that's possibly why there aren't many trials looking at new drugs with these types of cancers. And then the other question that people ask is, can I have immune therapy? So many patients are benefiting from immune therapies in this country and all over the world with other cancers. Can I have immune therapy? Okay. And so does the lack of mutation affect the use of immunotherapies? Okay. Well, you can tell by the way I'm phrasing that question that it does. Okay. So the diagram in the middle shows a mutated DNA, which is basically a cancer, and that mutated DNA is coding for what we call mutations, okay? We call them neoantigens, okay? So the normal antigens that that cell should be producing are the blue blobs, and the mutated ones are the brown blobs, okay? And you can see that general cancers produce many, many mutated cells, okay? Many, many mutated neoantigens. Lung neuroendocrine tumors don't, because they don't have many mutations. Okay, why is that relevant? Well, neoantigens are immunogenic, so these brown blobs are the things that bring the immune system in, okay, and make the immune system aware that something's not right. If you're not producing much neoantigen, then you're not going to bring the immune system in. The immune system, its job is to recognize self, which is friend, and non-self, which is foe, and attack foe. Okay, so it shouldn't read for, it should be foe. Okay, and so the neoantigens are seen as foe. The normal antigens, the blue ones, are seen as friend, not to be attacked. Okay, if a cancer produces lots of neoantigen, then some of that neoantigen is going to start looking like foe. And in that case, the immune system is going to come in, and the immune system is eventually going to realize that cancer is not meant to be there, and so may get rid of that cancer. With lung nets, there aren't many neoantigens, okay? And so as a consequence, this is not a particularly immunogenic cancer. And so how does that fit in with the immune therapies? Well, so this is the immune arc, okay? So you have to release cancer antigen, this neoantigen, from the tumor. That has to be picked up by antigen-presenting cells. Then they have to say, this is foe, which then activates other killer T cells, okay? So these T cells, these killer T cells, are then programmed to go back to the cancer and kill the cancer. And the immune agents that we're using nowadays, they work at step 7. They stop the cancer's defense from those immune killer T cells going in. Okay, they form a blockade to allow those T cells to go in without being killed themselves. Okay, and the reason why these types of treatments don't work with the atypical and typical carcinoids is because if step 1 doesn't happen, so the neoantigen doesn't trigger the immune response, there's no point giving those drugs. Okay, and so that's why there hasn't been much action with atypical and typical carcinoids in this arena. Okay, very quickly, advanced disease. How do we treat advanced disease? Okay, so the important point from this diagram is that we have the secretors who have syndrome, and the evidence for this is well developed. And then we have the non-secretors, where the cancers grow like cancers, and we have very poor evidence. Okay, and this really needs to be developed. And there are a number of treatments that we can apply, but there seems to be no sequence, okay, globally. Okay, so we can surgically debulk a patient, we can use somatostatin analog for the patient, we can use everolimus, and then we've got all these other options. And clinicians all over the country and all over the world give these things in any order, and at some point the patient may reach a trial if they're lucky. Okay, but while this is going on, the problem is that we can't collate real world evidence for what works and what doesn't work, because everyone's doing separate things in the background of a rare cancer. Okay, and so really it needs to be organized. Somatostatin analogs, there is good evidence that they work. So the yellow line, once again, this is a survival curve. The blue line falls faster than the yellow line. The yellow line indicates the patients who were treated with somatostatin analogs when they first came in between 1988 and 2004. And the blue line looks at patients who were diagnosed before 1988 when somatostatin analogs didn't exist. And so you can see that the somatostatin analogs improved survival. And we know that there is some evidence-based PROMID and clarinet for non-pulmonary neuroendocrine tumors, and we have borrowed from that, and that's why our patients, the lung neuroendocrine tumors, receive somatostatin analogs, because we think it will benefit them also. But the evidence is generally lacking. It's not as if we didn't try. We tried a trial. We ran a trial called SPINET, trying to use lanreotide to see if it had the same effect in terms of survival, but accrual, we couldn't accrue fast enough. Okay, then there have been trials looking at dose intensification and combinations. There was a drug called pasriotide, which Novartis almost developed. We had a positive study. I was the chief investigator in that study, but then they, due to financial constraints, dropped the drug, okay, which was a bit of a shame because it was a good drug. What about chemotherapy? Well, who do we use chemotherapy for when they've got well-differentiated lung nets? We use it for patients who have failed other therapies. We use it where the histology, the grading is high, okay? So grade 3 nets, more than the atypical nets, more than the typical nets. And this is where, when the clinicians tell you we're going to use chemotherapy, it all makes sense about grade of cancer, okay? Ki-67 score, when that is high, like I said, if the Ki-67 is high, it means that the cancer cells are replicating, and that's where chemotherapy is most effective. Rapidly progressing cancers, where clinically we're not gaining control using somatostatin analogs, it just makes sense to go in with chemotherapy. Where the patient is symptomatic, okay, don't forget patient choice. You do have a choice in this, okay, and the more you are informed, the more choice you can make, okay. And of course, when the oncologist is interested in pulmonary nets, they have an instinct about when to use chemotherapy. But remember, a lot of this practice is based on the work done in pancreatic nets. Temozolomide capecitabine is something that the group at the Christie have been developing for a long time, along with other groups around the world. I think it is probably the most useful combination of drugs for the well-differentiated neuroendocrine tumours. And it seems to show a good disease control rate. I'm not going to spend too much time with this. It's just broad principles that I wanted to cover with you today. I think this is quite a useful series of slides. Immunotherapy and targeted drugs. So one good example, one bad example, okay? This is how not to bring new agents into the arena of a particular cancer. So interferon, in the early days, in the 1960s, 70s, and 80s, was a very promising drug, marketed as a miracle drug. And it so happened that the neuroendocrine tumors were responsive to this thing, or we thought they were. But the trials that happened to try and bring this drug in, you can see number of patients was tiny, 29 patients, 27 patients, 16 patients. So they weren't, these trials weren't powered correctly, okay? And as a consequence, we never got a clear picture of responsiveness. So biochemical response varied from trial to trial, subjective responses varied from trial to trial, radiological responses varied from trial to trial, and as a consequence, this never got established as a treatment, and it died a death. So no consensus agreement, never used. This is an example that is good, how everolimus came into the arena. So everolimus came in, initially, there was a trial called Radiant 2, which had lots and lots of patients in it, 429 patients, and a small cohort of them, about 10% of patients, were lung neuroendocrine tumours. At the end of that trial, we agreed to do what we call a subgroup analysis on just those lung neuroendocrine tumours, and we found that there was a signal. So the next trial, we agreed with Novartis that it would have a pre-planned group of lung neuroendocrine tumours in it at a higher proportion, 30%, okay? And we, once again, at the end of the trial, looked at it now because it was pre-planned. Statistically, this trial gave us much more information, and we found there was a strong signal. And so at the end of it, we were rewarded with a lung net trial on its own called the LUNA trial, which gave us the strongest signal. And so as a reward for that good practice, there was a consensus agreement, and NICE approved this particular drug for lung nets. And as it stands, it's the only approved treatment for neuroendocrine tumours of the lung. It was a global effort, and that's what it's going to require. It's going to require a global effort. PRRT, I'm not going to spend too much time on this. So just to say that there is efficacy in lung neuroendocrine tumours. The problem is that lung neuroendocrine tumours do get pushed to the back. And the trials often cover the non-pulmonary nets, and as a consequence, NICE approved for the extrapulmonary nets rather than the pulmonary nets, and so that's a frustration for us all. Okay, but really, globally, we need to just pull together as clinicians. But there are 7 studies which do show good efficacy. Okay. So at the Christie, there is a sequence of therapies, okay, and it all depends on how that patient is individually, okay. So surveillance, that is not do nothing, okay. Surveillance is probably the hardest management in medicine, okay. And then if a person relapses, if they relapse slowly, it's somatostatin analog. If they relapse more rapidly, it's chemotherapy. If they relapse from those 2 agents, we use everolimus as second line, and we look for trials, okay? And we use drugs like oxaliplatin and irinotecan in service development programs because we can't set up trials for such few patients. So we run them as audited programs. And of course, PRRT is something that really needs some work on in the UK and globally to try and get it higher up the food chain in neuroendocrine tumours. When in the treatment hierarchy do patients get different treatments? Well, as I've explained, aggressiveness of the cancer, so that's demarcated by Ki-67 score, histology, spread and rapidness of spread of disease. We also look at previous history of response, so don't forget, you can re-challenge. If you've had a treatment many years ago and it worked, and you had a good duration of relapse from duration of relapse-free interval from that particular condition, you can go back to it, and sometimes you have to remind the clinician to go back to it. Okay, so keeping a log of your treatments, end and start dates, and when relapses happen, etc., it's useful. What the patient wants or does not want is the most important thing. We can't give a treatment without a patient giving us consent, so that's always worth remembering. Okay, you are the boss. Okay, and of course, it is all dependent on the physician leading the care. Okay, there is a postcode lottery in this country, which I have mentioned nationally, but I think we're working hard to improve that. And these types of groups work hard to improve that themselves. If we get things right, there is a reward. Okay, if you have a disease group where you're organized and you have a pathway that's set, etc., then companies will come to you with drugs, and that's what we found with pancreatic nets and with GI nets, and we want that with the lung nets, but we can only do that through organization. It's carrot and stick. Okay, and so I won't bore you with that slide. And I just want to kind of leave you on this example. Okay, so I look after 2 cancers which are both orphan cancers. Okay, it's because the Christie don't like me, and so they give me cancers where they're regarded as orphan cancers. So gastric cancer is an orphan cancer, and lung nets are an orphan cancer. Okay, but you can see from this diagram that gastric cancer is well behind all the other cancers in terms of funding and in terms of survival. Okay, so the blue or I can't tell the colours here. The blue, lighter blue colour graphs, they depict survival, median survival, 1971, and the purple lines graphs, they depict the median survival in 2007. And you can see gastric cancer, practically no improvement, and that was because it was underfunded, under-supported, the pathways weren't developed, all the problems that we're seeing with the lung nets currently. But if you look at the level of evidence for supporting our practice, okay, even with this underfunded orphan cancer, gastric cancer, we're using level 1 evidence and level 2 evidence for practically everything. Look at how far behind lung nets are. We're using no evidence for somatostatin analogs, level 4 evidence for chemotherapy, level 4 evidence for PRRT, level 2 evidence for everolimus. So we are so far behind. We've got a lot of work to do. So the unmet needs are obvious. We need to improve the diagnostic pathway. We need to centralize and protocolize the treatment pathways. So I've often said hobbyists. We've got no room for hobbyists in this speciality. We really need patients to say, look, I'm willing to travel. I will travel. And many of you do, and I thank you for that. But that's the only way we're going to do this, by keeping careful databases of what we're doing and protocolizing everything. We need to better understand the disease, and I'd like to hope that I've kind of illustrated that through the immunotherapy story and the molecular mutation story. Just throwing drugs at a particular cancer because we can actually does us more damage in the long run, because then the investors get discouraged to ever come back to us. Need to base research on our understanding of the lung nets and its molecular pathology, absolutely key. And of course, research needs to be global and multi-centre. We all need to work together. And by that, I don't mean you guys, because you guys are. I mean us, the clinicians. Thank you.